This is Paul Jarris, the Executive Director of ASTHO, and I'd like to welcome you all to this webinar on Million Hearts, and particularly focusing on collaboration between public health and primary care and health care in the improvement of hypertension. This call is the result of a prior all partners call that we held with the ASTHO-Supported Primary Care Public Health Collaborative of over 60 organizations, following up on the IOM report, Registry of Public Health and Primary Care, and really trying to take that to the level of the practitioners in public health and health care. One of our calls, we had from both the AMA on their work around Million Hearts, as well as Dr. Harry Chen, who is the Commissioner of Health in Vermont, and there was a considerable amount of interest in the work being done on the Million Hearts in the States, and requests for a more in-depth webinar to follow, which is what we're holding today. So thanks for joining us. For those of you who are also part of the collaborative, I'd just like to update you to say that we had an excellent meeting last week here in Washington where we updated the strategic map for the next 2 years, and we will be sharing that updated map with you in the relatively near future on a partners call as we go forward. It was a time to recognize the significant accomplishments and successes over the past 2 years, but also take a fresh look at how the collaborative can move forward in the coming 2 years. I'd like to recognize two people in particular on the phone. Barbara Bowman is from the CDC Division of Heart Disease and Stroke, who has been supporting the work ASTHO's been doing with the states, and we want to thank Barbara for that. And Janet Wright is also on the line, who leads the Million Hearts Initiative for Health and Human Services and has been a tremendous partner and thought leader in the area of Million Hearts. So ASTHO, for a number of months now, has been holding a collaborative of 10 states as they work in particular, again, on hypertension for improved detection and treatment, working with primary care providers, working with insurers, and other policymakers. Today we'll be hearing from 4 states, New Hampshire, New York, Oklahoma, and Vermont, highlighting their work around Million Hearts and hypertension with an emphasis on integration of public health and primary care. For your information, because we have so many people on the call, your lines are muted at this time. When we get into the question and answer period, you press *7 and you'll be unmuted at that time. So with that, let me turn it over to Sharon Moffett to get us started on the slides and the presentation. Sharon?
Yes, hello everyone, and thank you for taking this Monday afternoon to join us, and we look very forward to hearing more from our leaders in several of the states, as you'll hear. What we really are focusing here, as Paul has indicated, on hypertensive control. And as many of you know, through the Million Hearts Initiative, our focus has been overall on the ABCs of heart disease and stroke. But particularly this initiative you're going to hear about today really looks at the importance of hypertensive control, and particularly looking at the life loss due to heart disease and stroke, with hypertension being a major risk factor for cardiovascular disease. We're looking at essentially a prevalence of approximately 31%, representing 68 million adults, and hypertensive increases with age approximately to 70% among all persons over the age of 65. That's a high priority for our nation to be considering hypertension. It is 1 out of every 7 deaths in the United States. So a key opportunity for us to look at what are the interventions that are going to make a difference. And as Paul indicated, and as you will hear, it's really through that systematic work together of public health and primary care, taking a focus on hypertension, that we feel some very important lessons have been learned. As we go forward and as we look at Million Hearts, as I've indicated, we have an ambitious goal here set forward by the Million Hearts to prevent 1 million heart attacks and strokes by 2017. I hope you'll see in the work presented today that we have some significant learnings and opportunities that will hopefully bring us well towards achieving that goal for 2017. The next slide I'd like you to look at is, as Paul mentioned, the Million Hearts Learning Collaborative. And just to give you a very brief overview, and many of you are aware of this work, ASTHO, with the support of CDC and Million Hearts Initiative, brought together 10 states to have a learning collaborative between clinical, community, and public health partners, really looking at what the best practices in evidence-based and policies to identify and control and improve blood pressure. What you will hear today, I think, is going to be critical in understanding that it is no one entity or no one stakeholder that makes a difference, but it was a combined systematic effort of all these partners that is really making a significant impact. So with that, I'd like to actually turn to our first speaker, Dr. Jose Montero from New Hampshire. As you can learn from some very important and exciting work that New Hampshire has, Dr. Montero began his service in New Hampshire in 1999 as the chief of the New Hampshire Communicable Disease Section in the Division of Public Health before becoming the director of the New Hampshire Division of Public Health Services. Dr. Montero is a state epidemiologist, an adjunct professor of family medicine, and a member of the Preventive Medicine Residency Advisory Committee at Dartmouth School of Medicine, and also is our past ASTHO president as of 2 years ago. So, Dr. Montero, please, we're eager to hear your wisdom.
Thank you, Sharon. Good afternoon, everybody.
The conference has been muted.
Hello? Sharon, can you hear me?
Sure, we can hear you now.
Okay. Thank you. Good afternoon, everybody. Just had a problem here with the computer. Thank you, Sharon, for the introduction. I hope that we have a quick presentation today where I can highlight on behalf of my team all the work and progress that has been taking place in New Hampshire. So if we go to the first slide, perfect. What are we trying to do? What is the model that we are using for this collaborative here in New Hampshire? And what we are doing is not reinventing the wheel. We have been working for quite some time and looking at specific progress happening in some areas of the state. In the Cheshire Medical Center area, we have been looking at the work being performed to improve high blood pressure, and they went actually from having numbers in the 60s to over 85% of their patients with high blood pressure control. And while doing that, they uncovered several new patients that were included in this. So it's not just taking care of those who they knew, but doing a wider search and incorporating those in the management system that they developed. So what is the management system that they developed? The first thing that they did was to create a registry. And that registry has a dashboard for each physician where they can see who their patients are, what their status of those patients is, if they are controlled or not, and it has some comparison level with the rest of the providers, which allows the clinicians to know if they are doing within the average of the system, way below or way above. This is a non-profit hospital. So they had to create a system and incorporate new people that was going to help them with the outreach to these patients and to pay for and distribute some specific educational materials that were designed by them, like a card that is used for patient engagement and clinical reminders of where they are and what they need to do. Those things are being paid for with money from the community benefits, which is quite an interesting and appropriate use of those resources. So that is the model that we are using. So what we're going to do and are doing and continue to do, as it shows in the next slide, is to move this experience to a wider group. We partner with a couple of community health centers and local health departments in the cities of Nashua and Manchester and propose to them to expand this model that was developed in the Cheshire Medical Center area and implement at their level. Now, when you look at the picture here, you see ethnic and racial diversity, and that's something that for us is quite important to highlight, because the perception is that New Hampshire doesn't have ethnic or diversity, which when you look at the aggregate numbers of a 94 or 95% U.S.-born white population, seems like that. But when we go to these two cities and the population served in those two community health centers, the proportion is completely different to what we see anywhere else in the state. So this was really important for us. And the other important thing for us to engage with these community health centers is that in New Hampshire we have something that is unique. Well, no, let me rephrase that. That is quite important. I don't know if unique. And is that all of the data needs for all of the community health centers are managed through a central organization that is called CHAN. And these provide different levels of service to each one of the community health centers for data management. So anything that we can do with one community health center data approach can be later on replicated with others, because we create a template that doesn't need that much transformation to be used elsewhere. So we choose these two to get started because they have the higher mix of poverty and chronic conditions that we were aware of, but at the same time allowed us to create something that we could then use to move elsewhere. And this development of the registry went beyond high blood pressure, even though that is what we are using currently. But we don't want to waste an effort, so the registry includes some demographic data and other chronic conditions like diabetes. It has a space to capture a mental health diagnosis and needs for transportation and the self-management goals that the patients may have. We are not using all of the components of the registry at this stage and in this project. Again, we don't want to have to go back and build again, so we build in our key areas and allow to grow from there. So that brings us to the intervention, and what we're doing there, as you can see, is the creation of the registry. And with that registry, we're creating dashboards that the clinicians in those two new sites can see at the same way that it was done in the previous place. And then the community-based blood pressure screening tool card has been used to advocate for the development of screening sites at the local health departments, as well as parish-based and community-based settings that we didn't have before. And because the population, we translated those cards into other languages that you see in the slide, Spanish, Portuguese, and Portuguese. We run into some design issues with the Arabic card, and we are working on a specific design for that population with that language, because the small print and the portability design doesn't work well with the type of symbols that Arabic uses. So for us has been a whole new learning process. So as you see here, the intervention includes community-based blood pressure screenings, working with the providers, developing a how-to use of the dashboard of the registry, and an executive version of that goes to the clinicians so they can improve. And it has actually given us really good results, as we show in the next slide, where we already know that the community health center, the Manchester and the Community Health Center and the Lamprey Health Center, which is the name of the federally qualified health center in Nashua, are already using this report. And we include the NQF-18 to be fully reported starting July 1st of 2014. That's an important point because it means that they're going to be reporting two different measures, which is a hassle, but since we don't have agreement between the federal partners of what they each request, we have no alternative than to include them both so we can really measure progress in this area. And you see in the upper right corner, in Lamprey, we started at 52% of control. We are already at 61. In Manchester, we started at 66, and we are now at 72. So you see already progress in this couple of months of 20% increase in Lamprey, 10% improvement in Manchester, which is really great progress for such a short period of time. We have distributed the cards, as you see in the lower right corner, and reach out to many members of the community, especially engaging those of ethnic and racial minorities that, as everywhere else in the country, are a disparate population that has not the same level of access. But then in the left bottom box, you see a couple of basic things, and one is the standardization of the screening measuring. It goes without saying that unless you are always measuring the same thing and everybody is doing it, you may get different results. And unless you go and you measure how you are measuring, you are not going to find out how different the measures and the approaches are by each clinician. So this improvement has been really, really great for us, which brings us in the next slide to highlight a couple of things. Is that we are doing really systems change. This monitoring of the NQF-18 aligns our primary care traditional indicators with the indicators that are asked by the Million Hearts. It is a duplication, but we're trying to go with the flow and get to work on that. Certainly the development of the Registry Lite as a customizable registry tool is really important because depending the needs of the patients, the programmatic needs of the system, the different dynamics of populations, we can personalize these to each one of the institutions where we hope to expand this later. And that, again, is an efficiency tool for us toward the future, which brings us to the next slide and final one, where we are already fully engaged with the communities, got the YMCA to offer reduced or not cost membership to patients at the Manchester Community Health Center, which is part of what we are trying to do as an expansion of this and maintenance toward the future, and certainly a better communication with the refugee and immigrant programs is really important for us. So thank you very much. We will transition to Terry, I think, Sharon, and happy to answer questions at the end.
So Jose, I recall from hearing from the clinics there that the importance of having those active registry managers, a passive registry didn't make a difference, but they brought on a couple of lay people to interact between the registry, the doctors, and the patients, and that made a huge difference. And as you mentioned, how unique to have the community benefit from the hospital pay for that. So, Sharon, did you introduce Dr. Clyne?
An excellent summary. I think we're moving on to Dr. Terry Clyne.
Dr. Clyne, you may need to unmute by hitting *7.
I'm here. Can you actually hear me?
Yes, we can.
Okay, here we go. So if we go to the first slide, let me start by expressing my thanks to ASTHO and to CDC, and a special thanks to Jose with his President's Challenge. We're looking at the integration of public health and primary care. This falls right in line with that. So as you can see from the slide, we really had as our goal to reduce the number of cardiovascular events occurring in Oklahoma. And heart disease accounts for approximately 30% of all the deaths in Oklahoma. So we have more than 4,000 avoidable deaths in 2012 among persons younger than 75 years of age. And we know in Oklahoma in particular, the proportion of the adult population, about 36%, are diagnosed with high blood pressure, and that's more than the United States, which comes in at about 31%, according to Burfus. So it continues to be in the top 10 leading causes of death in Oklahoma, and deaths due to heart disease are ranked number 1, and stroke is ranked number 5. So we've moved to this model, and again, appreciate the support in being able to implement this, looking at the integration of primary care diagnosis and treatment with pharmacotherapy assessment medication, and then using a coordination care model, actively engaging the local public health department. So we know from CDC we have a lot of people who are engaged in the system but still are not managing adequately their high blood pressure. And so our goal is to actually move that into action and improve the outcomes. The key concepts for this actually include using the NQF 18 and using policy and adjusting our reimbursement models toward prevention. So we've seen great results to date, actually moving collaboration to a much more higher level of engagement. We have an integrated referral system, and we've chosen the southeast part of Oklahoma, which actually has a very, very high rate of hypertension and high blood pressure. 41% of the population in this region are actually diagnosed with high blood pressure, which is significantly higher than the rest of the state. So we're going right to the heart of that. Then we hope to align our treatment care system to pay for performance rather than a fee-for-service system, and engaging the public as well as the private sector. If you go to the next page, looking at systems change and partners, you can see that we, using the NQF 18, want to make sure that we have an established standardized protocol. We have policies that actually encourage the use of that protocol, and really utilizing more the electronic health record. And this is a challenge in this particular part of the state, where only about 30% of the 60 providers in those 5 counties have electronic health record capable systems that would be able to run these panel measurements. So these are the kinds of challenges that we're encountering. We actually contracted with our state-based quality improvement organization separate from the health department to do specific training with the clinics to make sure that they are able to utilize appropriately the electronic health record. So we had 25 providers who received 3 visits of this training, which we think was very, very effective. And then adjusting this pay-for-performance contracts, we are focusing on reimbursing providers for patients who successfully achieve a blood pressure of 140/90, or whatever goal is set by the referring physician, realizing that and recognizing that may vary by patient. And again, the physician is the group that is in charge of that particular outcome, and we want to make sure that we're reaching their goal as well. We think it's important to be able to have a team of stakeholders engaged who will continue on this work, and we believe we're on the right track and actually just getting started with this. And it will be important to articulate a return on investment so that we can achieve some sustainability and, again, meet the bottom line for insurers and providers. If you go to the next page, you will see that we have a number of partners and really excited about this. Blue Cross Blue Shield is the largest private provider in the state. Really would like to thank Ted Haynes, who's the president and CEO of Blue Cross Blue Shield, and Joe Cunningham, who's the medical director, for their leadership. They've been fantastic champions. But a relatively small number of insured lives through Blue Cross Blue Shield in that part of the state. But this gave us an opportunity to look at that work in the private sector. So to expand our reach, we've actually engaged with the Oklahoma Healthcare Authority, which is the state Medicaid office, and we'd like to thank Nico Gomez, who is the director for the Oklahoma Healthcare Authority. And this actually will allow us to increase the number of patients enrolled in this 5-county area. And the Healthcare Authority, just through their own data management, have identified about 400 patients who have a diagnosis of hypertension, but that do not appear to be well controlled in the management of that hypertension. So we will be able to engage with them. As you can see, there are a number of other partners in this process who have come to the table, including the Choctaw Nation, Warren Clinic, and McAllister Regional Hospital, among others. Pharmacists absolutely stepped forward, and I'd like to thank Michael E. Kelly, who's the county director for Pittsburgh County Health Department, because he's really brought his team on board for that care coordination through the health department. So fantastic to have this group engaged. The University College of Pharmacy actually sent one of their faculty to our last meeting there in D.C., and we're very appreciative of that as well. And if you go to the last page, we look at really what we hope is just the beginning of ongoing work, and we realize we're just getting started. We've begun that dialogue. This is the concrete work that you need to sit down to the table and engage in this work, actually pushing evidence-based strategies, which have not uniformly been applied, but great to have everyone on the same page, making sure that we are bridging the disciplines and developing a track record to demonstrate that this can be done and will be successful and all parties benefit from that, and then leveraging those partnerships, making sure that we're bringing everything to the table to improve health outcomes in this very challenging part of the state, which we believe could be a model for the rest of our state. So with that, I will conclude my comments and close by thanking John Lowry on our staff here at the Central Office for the Oklahoma State Department of Health, who's really been the glue, who's pulled it all together, and as well as providing the steam to keep the engine moving down the tracks. And with that, I'll close. Thank you very much.
Thank you, Dr. Clyne, and I apologize if we didn't introduce you formally. I guess you're so known to so many of us that we should never make that assumption, though.
Not necessary. Thank you, Sharon. Thank you.
Okay, and thank you. And I think for those of you that have listened, again, remembering if you have questions for our speakers, you can use the chat box, and we will be opening the call at the end for open discussion also. And to highlight some of the unique parts of Oklahoma's work, again, their partnership with Blue Cross Blue Shield, and I think particularly they're targeting a high-need area and unique area of their state, but also looking to that ability to replicate and sustain that work going forward. So we'll be looking forward to learning more from Oklahoma as you continue your work. It's now my pleasure to introduce our next speaker, Dr. Gus Burkhead from New York. Dr. Burkhead is the Deputy Commissioner of the Office of Public Health in the New York State Health Department. He's the department's Chief Public Health Physician. He joined the department in 1988 and is a graduate of CDC's Epidemic Intelligence Service and Preventive Medicine Residency Program. He is board certified internal medicine and preventive medicine. In addition to his work at the health department, he's a professor of epidemiology at the School of Public Health and the State University of Albany. So actually, Dr. Burkhead is a perfect example of the true integration of public health and primary care all in one person. So Dr. Burkhead, please, we look forward to your discussion.
Thanks for that kind introduction, Sharon. I think I would probably be dangerous, however, in a clinical setting at this point, since I've been really devoting myself to public health for the last 25 years. But thanks, I appreciate that. And thanks to ASTHO for the call and for the collaborative that's really been very helpful for us to get our act together here in New York. And I wanted, in the next slide, go to the next slide, just talk about three different areas in general that we've focused on in our collaborative. These are not directly related, but are all around the area of hypertension control. So the first area is we've partnered with three FQHCs in three different counties with their local health departments to try and improve hypertension control in the patients in the FQHC. And this has been a real partnership. The county health departments have brought some of their information from patient surveys from their home blood pressure monitoring project to the table. And they've also provided training for the FQHC staff in proper blood pressure measurement and that sort of thing. And the county health departments have also conducted focus groups with the FQHC population who are participating in self-management programs that the county is involved with. The FQHCs, for their part, have done a better job of connecting patients with community self-management support programs through a statewide portal that we've put together. And the FQHCs have also looked at their data, and each of these three have the same EHR. And so we've worked with them to define the terms in EHR terms of what is undiagnosed hypertension and what is uncontrolled hypertension. And through the work of this collaborative, really over a 10-month period, 8 or 10-month period, we've been able to cut in half the percentage of undiagnosed hypertension and have had a bump up of probably 10% or more in the number of patients with controlled hypertension just in that short period of time. Some of that may be due to cleaning up the data and getting people focusing on the data, but that's a starting point, and we hope that we can sustain that kind of improvement going forward. The second area that we've been working on relates to our health information exchange in New York. We have regional health information exchange organizations, or RIOs, and in the capital district here around Albany, HICSNY is our RIO. So we've basically had two EHR or RIO-related projects, again, similarly trying to define in an HIE and look at a zip code level the prevalence of hypertension in patients in the HIE and control rates using NQF-18 and undiagnosed hypertension. So the same kinds of measures that the FQHCs were looking at individually in their EHRs, we're trying to look at a population-wide level. And in phase 2 of that project, we're going to look at how the community stakeholders can actually use that information. For example, zip code level information on uncontrolled hypertension feeds into the local county health improvement planning process, as an example. So the advantage here is that HICSNY covers a 17-county area, and they have a participation rate of 62% at this point of providers, including 610 outpatient and 27 hospitals, which is probably most of the hospitals in the area. So with this pilot that we've been able to support with the collaborative of looking at the EHR data in the exchange and looking at prevalence and control rates, we'll be able to expand that pretty much immediately to a 17-county area, and then we have a statewide system of these RIOs, regional RIOs, where we are linking them together. So ultimately, the work done here will be able to go statewide across all of our health information exchanges. The final area where I want to talk about today where we've been working is working with our Medicaid program, which is in the health department. So that's been helpful. And basically to use their claims data to provide feedback to the clinic on prescription fill rates for patients who are getting treated for hypertension. So our goal is to provide probably quarterly data back to the FQHCs on the initial fill rate on prescriptions for hypertensive medications, for particularly focusing on new patients who may not have filled even their initial prescription. And then the other kind of information we can generate from the Medicaid claims is the proportion of days that people are covered have an active prescription. In theory, if they're taking their medication as directed, they would be able to cover those many days and to try and identify patients who therefore have fallen through the cracks because they haven't come back or not refilled their prescriptions in a timely manner. So the combination of those three, if we can just go to the next slide, we wanted to just touch on the systems changes and the partners as the other speakers have done. In terms of system changes, I think we're really trying to make routine use of the health systems data that we have, both for population level improvement and work, but also in the individual provider settings. And then I didn't mention it, but we are also working with the health plans. New York is heavily managed care, and our Medicaid program is basically going to be 100% managed care within the next year or two. So we've involved them in this as well. And on the right-hand side, you can see that the partners have involved the health exchanges, our state QIO, the Medicaid program, the local health departments, the FQHCs, and not listed here, but the health plans as well. And just on the last slide, next slide, to just touch on going forward in the future, We have recently received a large Medicaid waiver approval from CMS, and a big piece of that is our Delivery System Redesign Incentive Program, or DSRIP, which is a standard, I've learned, a standard CMS lingo for the kind of health system redesign that we're working on here. But we're right at the moment asking at each regional level, local level in the state, the hospitals, the FQHCs, and other community providers to come together into what are called performing provider systems, and they will be asked over the next 5 years to commit to reducing unnecessary hospitalizations. And a big focus on this after they do a community health assessment is on cardiovascular disease prevention. And the information that we've put together in this ASTHO collaborative process will be very helpful. We are already trying to feed this information out across the state to local coalitions on how you bring your stakeholders together and what kinds of things you can do to improve hypertension control among many others. But we'll be focusing on all the Million Hearts ABCs in this, but it's an example of how the work that we've been able to do through this collaborative will now be able to go statewide. And similarly, New York is positioned now to apply for actual implementation funding, SIM funding from CMS, and we will build in cardiovascular disease and this hypertension work into that as well. So the last slide just is the contact information. I want to thank Tiana Wyrick, who's been our lead, and Pat Wineski and Barb Wallace, who are here sitting with me for all their work on this. They basically have done the lion's share of that. So happy to take questions at the end. Thank you.
Dr. Burkhead, thank you very much for a great, concise depiction of all the work that's going on in New York State. And I think you brought forward many particular points, not only unique to New York, but also some of those we're seeing in other states that aren't represented on this call today. Actually, all of the states working on the Million Hearts Collaborative are working with their FQHCs, and in New York, as you've indicated, there were 3 different FQHCs that you've worked with. You also brought up the quality improvement organizations as being a critical partner for you in New York, and we've also seen that being beneficial in several of the other states. And we'll all be looking forward to seeing the successes as you move forward with your Medicaid waiver. So those are just a few of several highlights, I think, from your presentation. We're now ready to move on to our last, but not by no means final, presenter today, and that's Dr. Harry Chen. He was appointed the Commissioner of the Vermont Department of Health in January of 2011. Prior to his appointment, Dr. Chen worked as an emergency room physician at the Rutland Regional Medical Center for over 20 years and served as the medical director in Rutland from 1998 to 2004. He's on the clinical faculty of the University of Vermont College of Medicine and serves as the vice chair of the University of Vermont Board of Trustees. And Dr. Chen has also been a legislator in Vermont prior to becoming the Commissioner of Health. So Dr. Chen, we're eager to hear and learn from Vermont's work in Million Hearts. Thank you.
Sharon, I just want to make sure, can you hear me?
Yes, we're all set.
Okay, great. So thank you, Sharon, for that introduction. And I know that I spoke previously about our experience with Million Hearts, and I certainly want to thank ASTHO and the CDC for their support for really enabling me to, so to speak, get my hands a little dirty and get our hands dirty in terms of integrating with primary care and in the efforts to control hypertension. As background, our partners really have been the Medicaid and our largest private payer, Blue Cross Blue Shield in Vermont, and we've been working with practices of various kind of strategic shapes and sizes, so to speak, the most urban areas in Vermont, which obviously doesn't get too urban, but also some of the most rural parts of Vermont up in the Northeast Kingdom, and then one kind of in-between area where a large FQHC provides the bulk of the care to virtually every resident in Rutland County. So we can go to the next, that slide's fine. The intervention really has been on the data side. We've been working with the Medicaid and, as I said, the Blue Cross private payer to calculate and report what we'll call medication possession ratios for hypertensive meds for select primary care practice sites. We're in the process of evaluating the usefulness of this data and using the rapid cycle change method. We're also, our activities include the acceleration award focus on our all payers claims database. So we're trying to work with a consultant to help lead the health department and our analysts to train other data analysts to use this all-payer claims database. We're working with our core team to compare hypertensive claims in this all-payer claims database, matched for the same service period, same zip codes and age ranges compared to an FQHC's hypertensive population, identified by their diagnostic codes. This FQHC, as I mentioned, in Rutland County serves virtually most of the populations in that area, and we thought it would be helpful to really understand and interesting to see how these two data sets align. In another case study, we'll focus on comparing rates of heart attack and stroke events and death caused by stroke, and using the comparing the all payers claimed database statewide with hospital discharge data and vital statistics. We expect that this use of the all payer claims database will be useful for examining, obviously, the cost of care. We've learned that that there is a difference between the outcomes data and practice that practices pulled together for mandatory reports, such as NQF 18 for the uniform data system, and how this differs from the more focused queries data managers in practices can pull together regarding blood pressure control to accomplish more frequent panel management activities. In terms of turning to the provider behavior, we have 80 staff members responsible for measuring blood pressure from 4 practice sites, attended classes on proper techniques for blood pressure management. As one of the previous speakers noted, important to make sure we're all measuring in the same way. We learned that one of the FQHCs in our state, actually not a Million Hearts partner, but one that we interact with regularly, was doing an especially thorough job of weekly panel management with hypertension chosen as one of their important conditions as a patient-centered medical home. And we visited this FQHC to gain a better understanding about their distinctions between the less frequent data reporting and the more frequent panel queries for the purposes of panel management. In terms of patient behavior, we distributed 144 digital blood pressure monitors to 10 practices, and we're really kind of working with them, seeking feedback from those practices to learn how data from patients was obtained and how it was used in this particular practice site. Finally, in terms of provider behavior, we just finished and actually posted on the web, and there is a link listed in the slides, a simplified DASH diet, and to be used with patients in the practices that are in the collaborative. The next slide. Talking a bit about the systems change with our partners. We're working with data managers, supporting the connection between an FQHC doing weekly panel management with one of our ASTHO partners, and a data management who are seeking to improve their use of panel queries by their staff. We're hoping to tease out what it is in terms of the qualities and the attributes of practice support necessary for efficient regular panel management. We've also, Vermont's State Innovation Model Grant Administrator, the Green Mountain Care Board, which is the overall regulatory board for virtually every healthcare activity in Vermont, has helped our ASTHO core team put together historical performance measures for HEDIS 2013 benchmarks for NQF 18, the blood pressure control measure, And the data are characterized by insurance plans that are either managed care organizations or preferred provider organizations, quote-unquote, less managed insurance plans. The regional and national averages are also provided so that practices could benchmark against larger regional and national groups. On the next slide, we've certainly want to report that ASTHO Million Hearts has created quite a buzz among our partners within the state, bringing in the health department and my involvement personally. It's been very satisfying. It's also important to use what we've learned in terms of data, use what we've learned in terms of how to use and analyze the all-payer claims databases to focus our continued efforts in terms of primary prevention and treatment of cardiovascular diseases. We feel like the Million Hearts grant certainly fees very perfectly well and aligns with 1305, the CDC 1305 grants. And we've actually discovered there are other grants regarding cardiovascular disease, just released the CDC 1422 grant, where we can use much of what we've learned in terms of our partners and the practices, the data and our ability to use the all-payer claims databases and work with the payers. And then finally, I want to mention it's certainly worth exploring ARC's resources on primary care practice facilitation at the website noted below. Our partner at the Vermont Blueprint for Health uses practice facilitators, and hopefully we're hoping to achieve more contact with them and additionally working with them and the local practice staff. So that concludes my remark. Again, I want to thank Robin Edelman, the principal investigator here in Vermont, and Jesse, who are sitting here in the room, Jesse Curran, for their efforts to really make this work on day to day.
Thank you very much, Dr. Chen. And again, I think there's several unique learnings from Vermont. I think particularly the discussion around the all-payers claim and their use of claims data. We're also very interested to continue to follow your work on the DASH diet and how that's being pulled in and integrated into this critical work. Also, I think a very important point you brought up is the opportunity to align and leverage other sources of funding to do this work. And lastly, all of you have recognized how critical your team has been to keep focused on this rapid cycle improvement process. And I again will go back to our funders from CDC that's been a critical opportunity to provide that funding to the states to get the team in place to assure the day-to-day attention to this change work is moving forward. So with that, I'm going to turn to Paul Derrick. We do have some questions that have already been posed, and then we'll open the line.
Okay, thanks, Sharon. Excellent presentations. I really appreciate it. We had two questions that are related, one from Deirdre Stockman, who asked if Dr. Burkhead could say a little more about how they engaged with health plans, including Medicaid MCOs in particular, and have there been any changes to the MCO contracts or quality measures used to evaluate the plans based on this work?
Well, thanks for that question. I think we have involved the MCOs in the areas of the three counties where we're working with the county health departments and the FQHCs. So they've been part of the discussion, part of the work group, the collaborative work group that's going on there. I guess I don't think that we've changed anything in terms of the managed care contracts at this point. These are basically our Medicaid managed care plans, I think, for the most part. Is that right? Mm-hmm. Yeah. So that's certainly something we can look for in the future. Our Medicaid managed care plans do have a sort of a public health component to the contract that governs things like paying for services that county health departments would provide around TB and other sorts of things. So we can certainly look at that, but I don't think we've made any changes at this point. We're really just about 10 months into this process. So that hopefully could be one of the outcomes of this project. I don't know, Pat Wineski's here with me. Do you want to comment?
I think the only thing that I would add is that this collaborative really created a forum for conversation between the health centers, the providers, and the health plans to identify areas where there are opportunities to work together to improve, population-level care, and identify areas, that they could explore together. So to that end, some of the things that the practices identified was they wanted a complete list of patients that were identified as their primary care provider. So being able to look more broadly across their entire panel of patients versus just patients that come into their health center for care. And then are there any opportunities to work with the health plans to do outreach to those who are assigned to that FQHC but are not coming into care? So how can they work together to bring those patients in? The other example was to get information about medication fill rates, which is difficult at the practice level. And with the plans and certainly our Medicaid partners here at the State Health Department, we have our pilot test around looking at Medicaid data to see if we can create a method for giving fill rate information back to those FQHCs. So those are two just very specific examples that came out of that conversation and that forum, and that opportunity will continue as we move forward.
So Dr. Clyne and Dr. Chen, did you have anything you wanted to add since you're both working with insurers in Vermont and Oklahoma?
We're right in the throes of it right now. In fact, I'm madly taking notes. We're going to be speaking this week before the stakeholders meeting on our virtual get-together. We're going to be speaking with Dr. Mike Fisher at Harvard, who's a medication adherence specialist. And I'm just writing down questions for him, and I'm happy to take by email other questions people have on the call. They can email me directly.
Okay, that's Robin Edelman speaking, and maybe we can put her email on the chat line. If you want to ask a question, you can raise your hand. If you look up at your webinar on the upper left-hand side, it says raise hand, and then the staff will know to call on you. While you're doing that, we had a question from Richard Dart. What work to best engage the private practices and groups to buy into Million Hearts? The common theme seems to be a system of some manner that provides data collection and feedback to the practitioners or groups on success or areas not meeting goals. Would anyone like to address that question of how did you engage the practices, and in particular, if any private practices you may have engaged?
So, Paul, this is Terry Clyne in Oklahoma.
Go ahead, Terry.
I'll take a stab at least part of that question with an answer here. We've put in some financial incentive, as you're aware, that we think was really important to at least send the message that the time is valuable and it's well spent to engage with this particular collaborative. Really what it allowed us to do is to have an entree to get our foot in the door, as we've heard from providers over and over, unfunded mandates and too many demands on physicians and healthcare providers. So it really gave us some credibility that we're serious about this in terms of putting our money where our mouth is and putting some money behind that to incentivize that. The other piece of that is, and we believe that it will become more apparent, it's a win for everyone. It helps the physicians better manage patients that they haven't necessarily been as successful in managing in the past. So as those data start to come back, we believe that we'll create that kind of that quality improvement cycle with the quick feedback for their providers so they can see the benefit of engagement. But I think it really took realignment of the incentive system for that initial engagement.
Paul?
Yes, Jose.
Quick comment on in addition to that mechanism, which we have not really used in New Hampshire, the payment incentive, we partnered with the Medical Society. to get a dissemination of this approach and have a partnership group at the Medical Society between public health and the clinical community working specifically on this project. In fact, the Medical Society put money to hire an intern to go around the practices in a particular region to try to proselytize about the approach. We are starting by showing the small cards and engaging the general providers and that as a first step for a wider engagement of private practices that we would love to do basically through the main insurer in New Hampshire. They are willing to work with us. It has been an issue of timing and funding, which we are trying to work through.
Mm-hmm. Thank you. So a provider detailing function. Marjorie Friends and Weiss, I believe you had your hand raised. You may have to hit *7. Okay. Perhaps not.
I'm sorry, I'm here.
Oh, go ahead. Go ahead, Marjorie.
Yeah, I was just curious because Nevada was one of the states that hadn't had any funding for heart and stroke disease, so we're kind of trying to play catch-up here with all the different things that are going on from CDC. I had a couple different questions. I was wondering, in the first presentation, they were talking about the hypertension registry, the patient hypertension registry. I was wondering if that was a statewide registry or if it was a registry within the PCPHs, and how was that funded?
Jose, I believe that was your presentation. Are you on the line?
Yeah, for the initial development of the registry at the original site at the Community Health Center, so let me backtrack a little bit. In New Hampshire, we don't get any categorical cardiovascular diseases funding either. So the way that we worked it out was we took a pilot site that was interested in working on it. They invested money from the community benefits, developed the registry and the people to teach and manage the registry out of the community benefits funding. What we are doing is through the ASTHO grant, expanded that toward what we call the CHAN, which is the network that allows all of the community health centers to have their data managed. So we developed the registry using the funds from this grant and are using it to teach and model behavior based on the success of the 2 sites where we are working right now. And from there, since it's already created, any community health center that wants to use it will be able to use it. Another characteristic is that we have been working with the community health centers for many years, and with one exception, all of them use the same electronic health record. So it allows us to really get to work with them on that capacity.
Great, thank you. I think we're running up against being out of time. Is that correct for our staff? We're going to 2 o'clock?
Yes.
Okay, so I apologize. We have a couple of questions that we have here from Matt Wynia and Lloyd Michener, and what we'll do is send those to the presenters to see if they can address them. And I apologize that we're out of time. Again, I want to thank you all for your interest in this. We have selected at least the first 2 years, or last year, of the ASTHO-Supported Primary Care Public Health Collaborative to consider Million Hearts an example of a way we can learn together. On your webinar, you'll see a couple of sites you can go to for more information. There's probably going to be more interest as we go forward and learn more in these collaboratives and can present them in other settings. So I think we heard a number of different interventions. Some of the common themes was clearly self-management support and tools for the patient, having a standardized algorithm when possible for the providers, having a registry that is actively managed between the providers and the patients and the practice, having common measures, and in this case of this grant we used NQF-18, but there's also a HEDIS measure, having transparent reporting of control to the providers, ideally with comparison to other providers. Team-based care was mentioned. Those teams include insurers, which are often not thought of when we think of team-based care, and of course community outreach. And then in Oklahoma they are working on pay for performance through a partnership between the health department, hospitals and providers, and their insurers. So I'm not doing justice to all that was discussed here, but there are some common themes. I think one of the things we've learned in this initiative is there is no silver bullet. You have to look at changing the entire system of care and all the supports for it. So with that, I apologize we're out of time, and I thank you all for coming in, and we will take some of these written questions and email them to presenters for follow-up. And I want to thank the ASTHO staff who put this together.